All right, I'm gonna get started. My name is Randy, and I won't make you introduce yourselves to me. I know most of you here anyway, right? And today my message is going to be on something I've called insufficiency syndrome. I'm going to talk specifically about women and about hormones. Okay, and I'll give you a little bit of background about why I'm addressing this. When people come to me and they don't feel well, as a provider, I think, what am I going to do about that? And when you go to doctor's offices, they will oftentimes prescribe a medicine, or they will prescribe a supplement, or they refer to a specialist, or they'll order a blood test, right? And I put all these slides here. So these are slides, these are copies of my slides if you want them. Or they send you to a therapy in some way, right? You go do a hyperbaric chamber treatment and you do something like that. These are all potential options that people can do. But I want to explain my approach, and I call this AMFAST because I run a neurological center out of Boise called the Mind for All Seasons. So when people come to me and they say, why doesn't my brain work? Right? See this picture? This is an actual brain. This is an autopsy done by a physician out of Texas. His name is Francisco Gonzalez Lima. He had a big life clinical trial in Sun City, Arizona, where people who had Alzheimer's disease passed away, and he did their autopsies within about 48 hours of their death. And then he would take slices of the brain that had been donated to science and compare it against people who didn't have Alzheimer's disease. How significant do you think the differences were? He sent them to pathologists, and the pathologists could not tell the difference between the people who died of Alzheimer's and the people who died of other causes. So if you just look at the anatomy of the brain, it's almost impossible to tell the difference. Isn't that fascinating? Okay. This Dr. Bredesen, he's a neurologist from California. He worked at UCLA and University of San Francisco. And he wrote this book called The End of Alzheimer's. And I want you to look at the subtitle: The First Program to Prevent and Reverse Alzheimer's Disease. That's nuts, because in our world, no one thinks you can reverse Alzheimer's, but he does. Right? He's run clinical trials about that. He describes brain health as a problem of inflammation in the brain and a problem with energy production in the brain. So I'm going to explain what those mean. Inflammation is the brain has an immune system. Okay? So that picture I showed you of the brain is only like 10, 20% neuron. And it's about 80% cells of the immune system. So everyone thinks your brain is just a bunch of nerves. It's not. It's a bunch of immune system cells wrapped around a nerve. So when the brain doesn't work, it's probably because the brain is inflamed. If I had gout in my knee, what would the symptom be? Swelling. It would swell. It would ache. Be terribly painful, it'd be hot and red, and I couldn't move it. That's the symptom. When the brain gets inflamed, what's the symptom? You can't find your words. You can't remember people's names. You see them at church and you know you should recognize them, but darn it, you can't come up with their stinking name. You can't remember what you did last week. The dates are getting past you. You're not thinking clearly. That is an inflammatory process in the brain. Now, it doesn't hurt like gout would hurt my knee, but it's a different body system. Okay. The second thing is energy production. Well, what causes that? If you want your car to run, you have to keep it filled with gas. If it runs out of gas, it stops running. It doesn't mean your car's broken. It means it doesn't have any fuel. The brain's the same way. The fuel of the brain, gasoline, unleaded, it's called ATP. Well, how do you get ATP? Blood flow and oxygen makes the fuel for the brain. There's more to it than that. Glucose. You have to have the fuel, the energy, the blood sugar, and then you have to have something else. This is my title, insufficiency syndrome. What is that? Well, it's either nutrients or it's hormones. If you don't have enough B12, you can't produce the energy to run your brain. If you don't have choline, which is a neurotransmitter, you can't run your brain. If you don't have folic acid, vitamin D, vitamin E, glutathione, you can't run your brain. And my presentation today is if you don't have hormones, your brain doesn't work. When I say hormones, it's the hormones you're thinking of. Estradiol, testosterone, progesterone, DHEA, pregnenolone, cortisol. Okay, these are the hormones. So my goal today is I'm just going to talk about hormones because this gets into lots of discussion, right? But I'm going to stay focused on this, hormones only. Okay. When I teach people about neurological problems, my goal, Mark's goal, is to say, is this a cognitive issue? Cognitive means can't remember important things I keep forgetting. That's a cognitive. Behavioral issue is my mood is in the toilet and I get anxious when I go to the grocery store. Those are mental health challenges. Okay, they're different than cognitive challenges. There's motor challenges. I got a tremor. It's a motor problem. I can have a tremor and not have depression, and I can have a tremor and still remember what I did 2 weeks ago. This is a motor issue. Sensory is another issue. So how about people that walk around with neuropathy? My legs numb all the time. I have a client out of Western Idaho who says, my legs are vibrating all day long. They have vibration in them. And it's worse when I go to bed at night. That's a sensory issue, right? When people got COVID, what was the number one early symptom of COVID? Loss of smell. That's a sensory issue. COVID was a respiratory infection, but it inflamed the brain. And when it inflamed the brain, we lost the sense of taste and we lost the sense of smell. So these are things that I'm always thinking about when someone has some sort of neurological problem. So people say, well, how do you approach that? Well, I think, is it infectious? Like COVID was infectious and it caused a sensory problem. Is it autoimmune? The most common neurological autoimmune illness is multiple sclerosis. But there's Parkinson's. Some people even think COVID long hauler syndrome is probably autoimmune. There's inflammatory disorders. When you have gout, the brain doesn't work very well because that inflammation travels right up to the noggin. Okay. For 10 years, I worked at the VA and I took care of elderly people who had dementia. And the first sign of a urinary tract infection was what? They lost their minds. You'd go in their room and you'd do something, they'd kick you and they'd scratch you and they'd bite you. And yesterday they were calling you by name and they were so polite. And today they just lost their mind. That's a UTI. So you can have an infection or an inflammatory process somewhere else in your body and it travels right to your brain. It can be a concussion. I took care of a person, I think in Illinois, sweet little lady walking down the street, and across the street there was a gas station and it exploded. One of the propane tanks exploded. It blew her against the wall and she hit the ground. I said, did you hit her head? No, but her ears started bleeding and her nose started bleeding. She sustained a massive concussion and she's 500 feet away and didn't even hit her head, but the blast created that concussion. So our focus was helping neurological issues. Sometimes they can be vascular. The number one cause of brain problems that's vascular is stroke. A blood vessel gets clogged or blocked, right? It can be metabolic. Did you know that Alzheimer's disease has been nicknamed diabetes type 3? You heard that before?
Just recently.
Yeah. Diabetes type 1 is when the pancreas fails and a little kid has to take insulin right away. Type 2 is lifestyle, where we have all these changes physically. Type 3 is now you get Alzheimer's because your brain is so insulin resistant. Insufficiency, oh, I'm getting back to that word. It doesn't mean anything. I made this up, right? Insufficiency, I already told you, it means you can't have good brain function in menopause. You can't have amazing brain function without vitamin B12. You have an insufficient amount of nutrient or hormone that supplies the brain. And the last one is hormones. Okay, so today I'm going to talk specifically about menopause. Those are my focus. And when I've given lectures, I can lecture on any one of these, right? Do this all the time. This is my focus today. So Dr. Del Bredesen, remember that neurologist said when the brain gets inflamed or when it can't produce energy, you're going to have a loss of brain function. And then he goes through and says, okay, why doesn't my brain work? I'm going to compare it to a car. If you go out and turn the car engine on and it doesn't turn on, what do?
You drag it.
You start trying to figure out, okay, I turn the key. If the key doesn't turn on, what might it be?
Battery.
The battery. What if I turn the key and it goes, okay, maybe the starter's bad.
Fuel pump.
Then I'm looking at the gas gauge and I'm looking at the fuel pump and I'm looking at, so we're starting to think through this. This is what I try to help patients do when they come in. How is it like a car? What can we figure out? Why doesn't my car work? And you've all been through this. So now we have to think of this from a brain standpoint. I'm going to focus on hormones. That's a little bit of a duplicative slide. Okay. Hormones, sometimes when I lecture, I'm going to talk about men's hormones. Before we started, Mark and I were talking about some of our clients where we've optimized testosterone. The whole world has cheapened hormones. We say testosterone is just for sexual or reproductive health. That's a lie. It's for brain health. Or we say estrogen and progesterone and testosterone in women, it's only for reproductive health. If we're not having babies anymore, we don't need it. That's not true either. They affect the brain. So let me just pound through these real quick. Female hormones are divided up into groups. Sex hormones, estrogen, progesterone, and testosterone. This is where I'm going to spend the bulk of my time. There are other hormones like thyroid hormone. If you don't have enough thyroid, brain doesn't work very well. If you don't have enough adrenal hormones, brain doesn't work very well. One of my patients today, we're working through adrenal problems. And when I say adrenal problem, I think it's autoimmune, right? We're looking at autoimmune markers against the adrenal glands. And neurosteroids. Have you ever heard that term before? Neurosteroid. I'm going to explain where that comes from. But my focus is sex hormones. Okay. The Washington Post just released this article on May 1st, 2024. This article is only like 7 days old. It's 1 week. I'm trying to make this as up to date as I possibly could. Because I do this for a living, people are always sending me, hey, what do you think of this? Look at this article. So I get these all the time. It really helps me kind of stay on top of stuff. This article was written, look at the title, No Need to Fear Menopause Hormone Drugs Finds Major Women's Health Study. Now that's different because most women have been told when you go through menopause, you use the lowest dose of hormone for the shortest period of time because hormones put you at risk for cancer and a blood clot. That is totally bogus. And this article frames the new perspective about hormones. Look at that. Typically, those under 60, the benefits of the drug probably outweigh the risk for the short term of menopausal symptoms. This is just starting to be talked about. The discussion is female hormones probably have far more benefit than they have risk, and that's not been the model for 20 years. The model before was, oh my gosh, don't take them, they're kind of risky, you're going rogue, you're living dangerous if you're on hormone replacement, okay? Women in early menopause with bothersome symptoms should not be afraid to take hormone therapy to treat them. And clinicians should not be afraid to prescribe them. This physician right here is the chief of preventive medicine at Brigham and Women's Hospital. So the mood about hormone replacement and menopause is totally changing. I like this picture because when I talk about hormones, these are the faces that I see in the audience. This is my opinion of hormones. I smile, I'm happy. They change people's lives. They make them feel better. But guess what? This is the medical community at general. Your doctor's like, oh, hormones, don't do it. They're dangerous. You shouldn't. That's terrible. The patients come with all of these perspectives. Oh, I've never heard that before. Are you serious? I don't know if my doctor's gonna like that. I'm skeptical, Randy. That's okay. So I want to show you other people's opinions, not just my opinion. And I've tried to pull off data from other doctors around the country. This lady right here, here's her website. Her name is Lisa Mosconi. She grew up in Florence, Italy. And she now is a neuroscientist at Cornell, which is in New York, Weill Cornell. And she's a neuroscientist and a neuroanatomist. And her exclusive focus is how hormones affect women's brains in menopause. She is amazing. Okay. So here we go. If you're okay, I want to play you a brief segment of a video. Okay. And let me go back
to burn glucose to make energy. If your
Let me go back. It started.
estrogen is high, your brain energy is high. When estrogen declines, though, your neurons start slowing down and
Oh,
You clicked it out.
estrogen literally pushes neurons to burn glucose to make energy. If your estrogen is high, your brain energy is high. When your estrogen declines, though, your neurons start slowing down and age faster. And studies are showing that this process can even lead to the formation of amyloid plaques or Alzheimer's plaques, which are a hallmark of Alzheimer's disease. These effects are stronger in specific brain regions, starting with the hypothalamus, which is in charge of regulating body temperature. When estrogen doesn't activate the hypothalamus correctly, the brain cannot regulate body temperature correctly. So those hot flashes that women get, that's the hypothalamus. Then there's the brainstem in charge of sleep and wake. When estrogen doesn't activate the brainstem correctly, we have trouble sleeping. Or is the amygdala, the emotional center of the brain, close to the hippocampus, the memory center of the brain. When estrogen levels ebb in these regions, we start getting mood swings, perhaps, they forget things. So this is the brain anatomy of menopause, if you will. But let me show you what an actual woman's brain can look like. So this is
okay. So I'm going to go to my next slide. Did you ever think that menopause causes problems in the brain because estrogen bottoms out? When the ovaries go to sleep during menopause, your brain suffers. It's not just an emotional issue. I think that we've conditioned women to say, well, honey, it's just emotions. No, it's neuroanatomy. This is brain science. Okay. So this is what she was going to talk about. And I stopped it because I just want to keep moving. This is a PET scan of a 45-year-old woman's brain. And the PET scan measures metabolism. Metabolism that's red means the brain is very active. It's kind of on fire and it's thinking and it's metabolizing blood sugar. This is the exact same woman's PET scan at age 53. And if you're not trained to look at this, I want you to look and see where's the red here and where's the red here. Look at this area. Can you see the difference? Look at the red here. This part of the brain is the hippocampus. This is where Alzheimer's disease starts. Prior to menopause, lit up like a Christmas tree. After menopause, it's silent. This woman does not have Alzheimer's disease. This woman has just been through menopause and it changes the way the brain functions. So this is a very good example when we look at a PET scan of how the brain metabolizes glucose. Remember, I gave the analogy of the car and the engine. The gasoline for the car makes the engine run. In this regard, estrogen is a form of gasoline for brain function and metabolism. Okay? If you want to follow Lisa Mosconi, go to YouTube. I just went to YouTube and I copied all of these summaries. She's lectured all across America. She speaks at functional medicine conferences. She's one of the most well-respected experts on hormone replacement, and she teaches at universities across the country. So when I talk to you about the benefits of hormone, it's not Randy's stupid opinion in Southern Idaho. I'm sharing the research that is dominating the arena right now. She also wrote a book. Here's her book. If you like to read, it's called The Menopause Brain. Brilliant read. Okay. Let's talk about another book that was written. There might be people who are on our podcast that are worried about estrogen, and they might think, well, I just heard estrogen causes cancer. And my response is, really? Have you had children? Because when you have children, your estrogen levels skyrocket. They're at the highest point ever. So if estrogen caused cancer, then every pregnancy would follow up with a cancer. That's not the case. Okay? So this is Avram Bluming. Avram Bluming is an oncologist. He spent his entire career doing research on breast cancer. That's his forte. He ran the National Institutes of Health Research Division on breast cancer for about 20 years. Okay? More than 2 decades, he's been studying the benefits and risks of hormone replacement therapy administered to women with a history of breast cancer. That's terrible. He puts women who've had breast cancer on estrogen. Oh my gosh. I'm losing my mind over this. Okay? Look at this subtitle. Why taking hormone in menopause can improve women's well-being and lengthen their lives without raising the risk of breast cancer. Okay? If you go to his website, he lists several opinions. Look at these opinions. There's no way to prevent or reduce Alzheimer's disease except estrogen. His opinion is you want to prevent Alzheimer's, you take estrogen. 7 times as many women die of heart disease as die of breast cancer, and HRT, which is hormone replacement therapy, can decrease the risk of heart disease by 30 to 50%. Oh my gosh, estrogen just doesn't protect the brain, it protects the heart. This is crazy, I'm losing my mind. As many women die annually following an osteoporosis hip fracture as die of breast cancer. Do you hear that? Do you hear there's just as many women every year that die of a hip fracture from osteoporosis as who die from breast cancer? And guess what? Hormone replacement therapy cuts the risk in half because hormones protect your bones. Now hormones protect the brain and the heart. Now it protects the bones. Women who take hormone replacement therapy can live 3 to 4 more years longer than those who don't take it. There's no evidence that supports the current medical advice to take the lowest dose for the smallest period of time. My sweet wife is not even in menopause and she's on hormone replacement because she feels better. And guess what? She's going to take it till she's 150 years old because I want her to age gracefully. Makes a huge difference, okay? Most studies have found that estrogen does not increase the risk of breast cancer, and it can often be given safely to women who've had breast cancer. That is so far from the current standard of care. We just hear, oh, you're estrogen receptor positive or you're progesterone receptor positive. You cannot take hormone. In fact, you should take hormone blockers. No, that's old research. How many people in this room work on a computer that was developed in 1990? Because if you do, you hate your life. Because that computer runs so slow and it's terrible. The current medical research is functioning on data that's 30 years old. And we still abide by it. It's like working on the old Apple computer that ran NASA in 1970. That's bad data. We need to upgrade the data here, right? Donna White, one of my absolute heroes, she runs a clinic called the Bioidentical Hormone Replacement Training Academy. I've done all of her continuing ed. She's absolutely amazing. Look at what providers have said about our training. You can go to our website, and these are all doctors that talked about how much hormone replacement has changed their clinics and have changed the people that they take care of. Mary Claire, she wrote the Galveston Diet. She works out of Texas, this cute little OBGYN, right? She just wrote a new book called The New Menopause. It's kind of a dumb play on words, the new menopause. What she's reflecting is, look, people who are up to date do not look at menopause the way they looked at a long time ago. We have a new view of menopause. That's what she's talking about. Get with the program. It's her gentle way of saying, pull your head out here, right? She goes on the circuit as well and talks about the new menopause. She's giving lectures, she's teaching, she's training, she goes to universities, she's educating people about the benefits of hormone replacement. This website is called hormonebalance.org. Dr. Rebecca Glazer, I spoke at a conference in Texas in 2012 for a company called BioT, Bioidentical Testosterone and Estrogen. I'll show you a slide here in just a second. Rebecca Glazer spoke at the same conference, and she spoke about the benefits of testosterone therapy in breast cancer. And if you go to our website, you could watch this lecture. She's speaking to a group of physicians about the benefits of testosterone. This has got to be 8 years old by now. She was teaching this 8 years ago. And look at these titles. The top 10 myths about testosterone in women. Beneficial effects of testosterone therapy in women. Testosterone and breast cancer prevention. Reduced incidence of breast cancer with testosterone implants. 10-year results. She's been doing this a long time. Okay. My point to this is it's not just estrogen that it benefits the brain, the breast, the heart, the bone. So does progesterone, so does testosterone. And there's been researchers galore that's been teaching this for a long time. This guy's name is Dr. Mark Gordon. He used to be practicing out of California. He now lives in Texas. He runs a clinic called TBIHelpNow.org. He works, I don't think it's exclusively with veterans, but it's primary with veterans that come back from war having had a blast injury or a traumatic brain injury. And his primary methodology of treatment is we optimize hormones before we ever do mental health medicines and before we ever do talk therapy. And he's not cynical or sarcastic, but he says, you can talk therapy somebody to death and they don't get better. But if you optimize all of their hormones first and put them into talk therapy, they do amazing. He has a fellowship program about traumatic brain injury and hormone replacement that I did in 2019. It was phenomenal. TBI Help Now. And if you go to that, he's got a science page where he talks all about Clomid in men. And that's where I kind of got that research. He's told me. Okay. BioT. Dr. Gary Donovitz is who invited us to go speak at a conference. This company is called BioT. Right up here, this stands for Bioidentical Testosterone and Estradiol. This is probably the largest pellet company in the country. Okay. Testosterone pellets are hormones can come in oral, they can come in creams that you rub on your belly, they can be a patch that you put on, they can be a little pellet that you insert in the hip, and it just releases hormones slowly over time. He talks all about that. And look at, I just took a screenshot of his page because right here, look at this. Estrogen, brain structure, and cognition in postmenopausal women. He posts a little trial there. And since I'm all about the brain, I like that. So I took a picture. He wrote this book, Age Healthier, Live Happier, Avoiding Over-Medication Through Natural Hormone Balancing. Pretty awesome. This is Dr. Weber. She now runs BioT. And this is the latest research article. Now, This comes in this little teeny journal called JAMA. Okay, Mark chuckled because that was sarcastic. That's the Journal of the American Medical Association. This is the Bible of the standard of practice of medicine in the United States. Okay, so if you read your scriptures and go to church, that's where you learn the truth. In medicine, the scriptures are JAMA. Now that's sarcastic because I think scriptures are far more important than JAMA. Okay, but look at this. The Women's Health Initiative randomized trials and clinical practice. This is a review. Look when it was printed. May 1st, 2024. This is the most updated research. It's only been out for 6 days. Okay. And look at what they say. Currently available formulations of hormone therapy, such as estradiol, include lower doses and transdermal routes of delivery. That means a little cream that you can put on your patch, which may have lower risk of thrombotic events, although these differences have not been demonstrated. So what they're gently saying right here is, we think this is a little safer, but we're not positive because we don't have clinical trials. Because remember, the old dogmas, they were dangerous. Now they're backtracking on that. They're kind of gently walking it back and saying, we think this might be a little safer. And this is what they say. Individualized patient care and shared decision making should be implemented taking into account the patient's preferences, the severity of their symptoms, and the cardiometabolic and general health status of the woman. That's the first time that I've read an article in JAMA that said, don't do hormones, they're dangerous. Now, as they walk it back, JAMA says, this is a shared decision between the practitioner and the patient. And we're going to make that decision based on the individual risks and challenges of those individuals. It's kind of a good politically correct statement to make. And then they make these statements. This is just a copy and paste right out of the article. Researchers found that hormone therapy did not increase mortality rates. That means death rates. In any age group. Any. It didn't increase the cause of death in 50-year-olds, 60-year-olds, 70-year-olds, 80-year-olds, 90-year-olds. Okay? There was no statistically significant difference in heart risk between hormone users and non-users. That means the old theory that you get a blood clot if you use hormone replacement, they say right there, no significant difference. Here's the next one. Stroke amongst hormone users is relatively low. 1 extra case per 1,000 women using the estrogen progestin therapy and no risk with estrogen alone. Here's what that means. 24 years ago, when they did the first trial, some women who were taking synthetic estrogens by mouth, it increased the stroke. Do you know how much it increased their risk of stroke? In the placebo group, that means people who are taking sugar pills. 1 stroke for every 1,000 women on the sugar pill. If they were taking the hormones, for every 1,000 women, it was 2 strokes. So they said it doubled the risk. The problem is it only went from 1 to 2, and we're talking about 1,000 women on therapy. Okay? So if I told you you had a 1 in 1,000 chance of a side effect, but you could protect yourself against heart disease, osteoporosis, dementia, brain fog, depression, and insomnia, would you pick it? Okay. Different forms of hormone therapy had opposite effects on breast cancer risk. Estrogen alone saw a 20% reduction in breast cancer. It doesn't cause breast cancer, it protects the breast. Okay. Breast cancer increased with the longer use of combined therapy. So what they're saying is, the longer you're on hormones, the greater the risk of breast cancer. Get it? Putting that into perspective, it's the equivalent of the excess risk of breast cancer associated with drinking 1 or 2 alcoholic beverages a day. So, when they say estrogen might cause breast cancer, don't take estrogen. but I'm gonna have a glass of wine every night before I go to bed because it tones me down. There's just as much risk in that glass of wine as there ever is in hormone replacement. It's identical. Does that put it into perspective? The whole world has a glass of wine, doesn't even worry about it. Bone fracture risk amongst hormone users was 33% lower in every age grade. I don't know about you, but most women that I've taken care of are at high risk for osteoporosis. Estrogen changes that. Okay. Donna White, that teaches the hormone replacement. She gives examples of different hormones, and I'm going to slip past these because you're probably less interested in this. Oh, I think this is really interesting. This is my up-to-date account. Remember, I had to get my continuing ed. Here's where I get all my pharmacy credit hours right here. Okay. If a woman is pregnant and she's going into spontaneous labor early, it's preterm labor, we want to try to stop it. Do you know what we do? We give progesterone. Progesterone supplementation to reduce the risk of spontaneous preterm labor at birth. Progesterone is so calming to the body and to the uterus and to the muscle tissue, it will actually stop and slow preterm labor. Now, I'm going to show you something that's a little disturbing. Okay? Progesterone alone can reduce preterm labor, and I walk through all this. I'm not going to bore you with the details of it because the science mind in me chooses stuff up and loves it, but you're probably getting bored. Progesterone is safe in pregnancy. Have you ever heard of the morning after pill or Plan B? Heard of that? Do you know what it is? It's levonorgestrel or synthetic progesterone. So on the one hand, natural bioidentical progesterone is protective to an infant in utero and protects the mother against preterm labor. And a synthetic version of progestin actually causes fetal death. Oh. Now you know why in the early clinical trials 25 years ago, the synthetic hormones may have led to breast cancer and blood clots because we equated synthetic was the same as a bioidentical, and they're not the same. As evidenced by the fact that progesterone natural protects pregnancy and synthetic aborts the baby. That's mind-blowing. One of my dear friends is an OB/GYN, and we've had lots of conversations about this. And one of the conversations went like this. I said, Dr. So-and-so, what do you think of progesterone versus progestin? And he said, same thing. I said, are you crazy? They're not even in the same universe. They're the same thing, Randy. They do the exact same thing. And my response was, have you ever used aspartame as a sweetener? Yes. Identical to table sugar, correct? It's identical, same stuff, right? And he's like, okay, I get your point. It's not the same. So I think a lot of the risk that's talked about in hormone replacement is thinking that a synthetic and a bioidentical are the same, and they're not. Okay? So these are all called My Way, Next Choice, Plan B, Mirena, the IUDs. These are synthetic progestins. They're not the same. People think they are, they're not. Okay? These medicines are contraindicated during pregnancy. They'll terminate a pregnancy, whereas progesterone protects it. So the reason this is the structure of a molecule predicts the function of a molecule. It also predicts the safety, and it predicts whether or not you're going to have adverse events from that. And so if you look at these, this is from the bioidentical hormone training that I did with Donna White. These are the science geeks in me that get really into kind of organic chemistry, show you that the structure of the molecule is not the same. We'll pass this. So bioidentical versus Mirena versus the pill versus Premarin and so forth, okay? Everything that I'm talking about today is a bioidentical. That's what I'm focused on. I don't use anything else. Okay. The only time I've ever written for a non-bioidentical, I told you I worked at the VA, taking care of these sweet little old ladies that were in a nursing home. And I remember right when I got out of school, I went to lay, she's lying in bed. She's kind of gnarled up with arthritis, frail and weak. And I said, hey, I'm here to kind of walk through your medicine. And I wanted to know what you think of that Premarin, because my goal was to get her off Premarin. She raised this gnarled, crooked finger and he wagged it in my face and said, don't touch my Premarin. I said, okay, I'm leaving it alone. Because it made that big of a difference. So even though it wasn't what I would have used, it made a huge difference for her. Okay. Bioidentical, the term does not indicate the source of the hormone, but rather the chemical structure. Bioidenticals in today's pharmaceutical world come from yams. We take a yam, we process that through a chemical process, change the structure and turn it into a bioidentical estradiol or progesterone or testosterone. Okay. So through a series of chemical processes, the plant molecule, which is structurally similar to a steroid hormone, is converted to a specific human hormone in a laboratory. The final product has no trace of the plant. It's just pure biology. It's now bioidentical to the estrogen made by the ovary. Bioidentical hormones convey the same action, the same effect, and they're metabolized the exact same way as the hormones made in your body. Same everything. Okay? That's the current science of bioidentical hormones. 100% all natural. Okay? Now, I wanted to show you this because in Alzheimer's disease, if I have 3 people with Alzheimer's, 2 are always women. 1 is men. Women get Alzheimer's twice as often as men do. And the theory is because of this. If we look at testosterone over the lifetime, here's men's testosterone levels. And we know that, right? Because men are frisky until they're dead, right? But these are women's hormones. Cycle, 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 menopause. They bottom out. We think this bottoming out of the hormones that happen in the late 40s to early 50s is one of the reasons women get Alzheimer's disease twice as often as men. Okay. Here's a little article about having a hysterectomy and the risk of dementia. The Mayo Clinic identified that women who have endometriosis or dysfunctional bleeding at early ages, and they have a hysterectomy in early ages, are twice as likely to have early onset Alzheimer's disease. That stinks. Now you know I'm such an advocate for hormone replacement, right? So the earlier the hysterectomy, the greater the risk. The longer the period of time without that hormone stimulus, the greater the risk of dementia, right? So here's my conclusion. I did pretty good, 45 minutes, okay. My question is there a safe place for bioidentical hormone replacement therapy in the aging senior? Here's what I mean by that. If you look at the nuance of the clinical trials, they say that women who are just entering menopause, there's no risk. But the older that they get, maybe there's now more risk because they're older. And my question is, I take care of a lot of 70s, 60s, 70s, and 80-year-old women. They've been in menopause for 20, 30 years. Is there a safe place for hormone replacement? And my response is absolutely. That is not supported by the literature. That's my opinion. Why isn't it supported by the literature? Because there is none. We have not done hormone replacement. We thought it was evil from the get-go. So we never put senior women on hormone replacement. We don't do it. So it's my opinion, not because I disagree with the literature. It's my opinion because there is no literature about that. but I have done it a fair amount. I take care of women who have dementia, who are not sleeping well, who have terrible mood disorders. And when they're in their 70s, I say, would you like a trial of a bioidentical hormone cream? Because I think it can help all of these challenges. I've been doing it for 10 years and I can unequivocally tell you it makes a huge difference. Okay? Is there an age at which we should not be doing hormone therapy? Like, is there a cutoff? Hey, when you turn 73, darn it, you better not. Oh, 75, absolutely no hormone therapy. And my question, Christine, is at what age do women stop being women?
They're dead.
Okay, so then my opinion, there is no threshold. I do not believe that you get to a certain age and you can't do it anymore. If you're female, you can do it forever. And you should have that opportunity. The article I read you from the Journal of American Medicine says it is a shared decision-making between the prescribing person and the patient. And it's no one else's bizwax. So just stay out of it. That's what I say. Okay. Does the risk of bioidentical hormone replacement exceed the risk of dementia? This happens to me all the time. I see someone in their 70s and I put them on hormones and their doctor calls me and says, "What are you doing? You cannot put this 70-year-old woman on hormones." And I say, "Why?" "The risk is so high." And I'm like, okay, look, there is a theoretical risk of a breast cancer or a blood clot. And this patient is failing now from dementia. They don't have a risk of dementia, they have the disease. And you're worried about some vague theoretical risk that might happen in some distant point in the future? Knock it off. Take care of them now. And about 50% of the doctors say, if you want to prescribe it, I'm okay with it, but I'm not doing it. I say, perfect, I'll prescribe it. Okay? Would you ever not treat other hormone deficiencies? If you came to me at 70 and your thyroid didn't work, would I say, sorry, you're 70. I can't take care of your thyroid. Would we ever do that? Not unless you want to malpractice. That's negligence. Would we ever say to someone, "Oh, your adrenal gland, you're an adrenal failure, you have Cushing syndrome, but you're 82, so I'm sorry, we're not going to treat you. You're too old for treatment." That is a kick in the pants. How about pituitary, Marco? We ever say to someone, "Well, your pituitary, you have pituitary adenoma. We're going to resect that, but at your age, we shouldn't optimize any of your hormones." Wow, that's crazy. I view that wackiness the same way I view hormone replacement. There is no threshold, there is no age, there is no disease process that says we can't do it. It's between me and the patient. And we share that decision making together, and we implement a responsible plan, and we move forward with confidence. Okay? Women never stop being women. I'm going to open it up for any questions or discussions that just. I feel like I'm in process with this.
Side effects. Negative side effects.
The most common, okay, let's take it by age group. In all age groups, the most common negative side effect is breast tenderness. So when women would tread of the menstrual period, they'd get some breast tenderness and then it would go away. So when we first start hormone replacement, that's not uncommon because the breasts are sensitive to that. And all of a sudden you stimulate that and the breasts get a little bit tender. That's probably the number one. The number two side effect early after menopause is bleeding. Because remember, in the menstrual cycle, there's an estrogen phase, and then estrogen bottoms out and progesterone goes up, and then you have a period where there's no hormones. So if there's no hormones, you don't menstruate. If all of a sudden I start giving you hormones, guess what I could induce? A period. That's very unsettling to a 75-year-old woman who hasn't had a period in 25 years. 25 years, all of a sudden they start spotting and they're like, oh my gosh, this is terrible. They instantly think I've got endometrial cancer. And my response is no. The uterus is sensitive to that estrogen and it will grow a lining of the uterus, and you grow enough and it'll just slough off, because that's what normal menstruation is. So in that case, stop the hormone for a couple of weeks, finish your period, and then we can get back started into hormone replacement, and then we cycle it.
Good stuff.
Okay.
So for birth control, are you saying that most of those are synthetic forms of hormones? So does that have all these side effects for women that I knew like had the Mirena on there, and a lot of common birth controls that everybody uses?
All forms of birth control are synthetic. I'm not aware of one that is bioidentical.
I know I was thinking like the copper IUD, I think, right? Maybe that's the one that's not so bad.
The copper IUD is not hormones. It's just an IUD. Yes, correct. So that is a form of contraception that just sits in the uterus as kind of an irritant, but it doesn't exude a hormone. So there's a really great book if you want to learn about hormone birth control pills. It's called This Is Your Brain on Birth Control. And the author's name is Sarah Hill. And she talks about birth control actually turns off the pituitary gland. So birth control doesn't function down here. Birth control functions up here, right? Even the Mirena IUD that's placed in the uterus, the hormone levonorgestrel affects the pituitary. That's how its hormone blockade stops.
And you're saying from the synthetic hormones, there's like side effects like breast cancer, right? So do you think that these, we'll find out later on that
Really, really good question.
probably causing?
Yeah, so I'm really careful when I give lectures to not disparage birth control, because there's a lot of women who are on birth control and they might feel like, oh my gosh, she scared me. I am at this huge risk. Okay, there's a time and a place, and that's between you and the prescriber. But my point is, sometimes we use birth control during menopause to halt dysfunctional uterine bleeding. And I think there's better ways to do that.
Or don't doctors also use birth control if you have hormone issues,
All the
like
time.
even your tubes are tight or things like that? I feel like that's an answer to hormone issues, is let's put you on some birth control.
No question. And the reason why most problems, if we were to boil down most menstrual problems, it's dysfunctional bleeding, right? Because women can feel bloaty and they can feel crummy and they kind of work through that. But it's when they start hemorrhaging and bleeding for 3 weeks, 4 weeks, 5 weeks, this turns into a problem where we've got to do something. So birth control pills are very effective at completely turning that off, because we change the cycle upstairs. So you block estrogen, you're not going to build up the lining of the uterus anymore. So that's a very different approach. The goal of that is I'm going to turn off bleeding and block all the hormones. And my lecture today was the importance of not blocking hormones for brain health. Does that make sense? So it's almost like,
Give them hormones.
yes, I'm a fan of giving bioidentical hormones in menopausal women for brain health. So it's a little bit different,
Yeah.
a little bit different discussion.
Okay, and then one last question. So when you say bioidentical, so I've seen like a place I go and get facials done, right? She does hormone therapy and she is a nurse and things like that. But is that like a question to ask whoever would be giving you? Is this a bioidentical hormone, or can you get a synthetic version, right?
I think you should always ask that question. That's a great question. If you're going in for hormone therapy, I think that it helps women to know, what question should I ask? What is the goal of my therapy? What am I trying to accomplish? So your first question was, is my goal to try to block a pregnancy? That has a totally different rhythm. If your goal is to optimize hormones or brain health or depression, I have an opinion that if women feel terribly depressed or have a lot of mental health challenges, we should optimize their hormones before we should start mental health medicines. Right? Because oftentimes if we optimize the hormones, the mental health gets better. And then we don't need a second medicine. One of the challenges with mental health medicine is the side effect, right? There's side effects where maybe the mental health medicine makes women just feel numb. I don't feel anything. My sex drive goes down. Weight gain is a common problem in mental health medicines, right? So yeah, that's a great question to ask. Tell me how you approach bioidentical hormones. What's the method? How do we track this? What's our goal? Excellent question. Yes.
You talked a lot about age. At what point is it just menopause, like the age of menopause? But you talked about some people do this younger. What symptoms would you look at, or why would you do it younger?
Okay.
Or
Great. That's a really good question. Thank you for asking that. So menopause is defined as 12 months with no period. So most women don't have a period in March and then not have one ever again. It's not that simple. Have a period in March and then it comes 6 weeks where it used to be regular and now it's 2 weeks late and have a period. And then it's normal for a month and then it comes 8 weeks late. And so they start getting really irregular. We call that phase the perimenopausal phase. Okay. So in perimenopause, common symptoms of why women would start hormone therapy are insomnia. They can't sleep anymore. Many women will start experiencing hot flashes, especially night sweats, in the middle of the night, even though they're still having a little bit of that irregular menstrual period. Some women experience vaginal dryness, so intimacy is not as comfortable anymore, right? Because of vaginal dryness. Other women get chronic urinary tract infections. Some have depression and anxiety associated with that, right? So there's a lot of variability in what symptoms they could be experiencing that would make that discussion of, hey, is hormone replacement or hormone optimization valuable? Another part of that is that when women start trending towards menopause, they lose progesterone first. Okay. Progesterone balances out estrogen. So when women get estrogen dominant, they start having heavy periods because they get estrogen dominant and progesterone's just not being released at the same as it used to be. So in early menopause or just leading into menopause, oftentimes we don't use estrogen because they're already estrogen dominant. We start using progesterone first. And progesterone is like Ambien. It's amazing. Women sleep so much better with a little bit of progesterone. Okay.
thanks.
You're welcome. Great questions. Any other questions? Do you have any questions?
What do you think of the trophy? Is that the way you pronounce it?
That's a great way. Yeah, perfect. Troche. So let's talk about forms of bioidentical hormones. Remember, bioidentical means that the hormone that you're taking is identical to what your body made naturally. But they come in different forms. We can get a troche, which is where the pharmacist puts the hormone in a little lozenge that you suck on. And instead of swallowing it, you just suck on it and the hormone gets absorbed through your cheek and through the blood flow in your mouth and goes straight to the brain, and it just feels amazing, right? So progesterone troche, it's like Ambien, you just go straight to sleep. Very nice. Testosterone in a troche improves libido, so that's a big deal for a lot of women. And estrogen, same thing. So troche is just a form, one way to receive bioidentical, and I don't have a problem with that's great. Some women don't like the taste of a troche. So we try to make a hormone taste good. So we're used to sucking on candy that tastes amazing, right? So you put a troche in your mouth and they don't necessarily taste like candy because I've tasted them. I've tasted progesterone. I've sucked on those troches and I just don't like the taste of them. So oftentimes if I take a little progesterone, I'll just throw it back in my mouth and swallow it. You can put it in a cream, you can put it in a patch or a film. So troche is just one form to take it. Great question. Lindsay, do you have anything?
I think probably just the same as her, like you obviously talked about a lot of like menopause, which like that doesn't apply to my life right now. So it's hard to like relate to it. But like I obviously don't have balanced hormones now. Like I know that I don't. And so, like, I think that that is more applicable. I don't know if that's how you felt about the question that you asked, is like, why, like where you're coming from, is like knowing that my hormones now are not balanced, and that is more applicable to me now.
I'm gonna
Like
go
my,
back.
I know my testosterone's higher now.
Yeah. I'm gonna go back to a previous slide. I'm almost there. Now you know what I do on my spare time. I build PowerPoint slides.
When do you have spare time for?
Usually after 11 o'clock at night.
I
or
was gonna
5
say,
o'clock in
when
the
you
morning.
can't sleep, right?
Yes, that's true.
There's something interesting.
Okay, this is probably the number one reason that people have this problem. Okay, so metabolic syndrome is doctor's code for insulin resistance. Okay, insulin is a hormone, and insulin governs estrogen. It masters estrogen. It masters thyroid. It masters testosterone. Did you know that bodybuilders who abuse insulin get bigger and bulkier and stronger than bodybuilders who abuse testosterone? Did you know that? Yeah, I guarantee you, half those knuckleheads at the gym down the street were lifting weight and getting huge. They're abusing insulin at the same time that they're using testosterone. Because insulin is a growth hormone. The number one side effect of insulin is what?
Diabetes.
It's weight gain.
Oh,
Okay. So if you look at a type 1 diabetic who is diagnosed in their, 10 years old, they're on insulin. Are they overweight? No, they're usually just wicked skinny, teeny tiny. Okay. If you see a type 2 diabetic who's on insulin, they're almost always overweight because insulin causes weight gain. So if the question that you asked me and I misunderstood it was, why would women take hormones prior to menopause? It's almost always because they have metabolic disorders, they have insulin resistance. And when insulin resistance happens, it causes imbalances in their hormone. And the number one hormone imbalance in the world is polycystic ovary syndrome, PCOS. And PCOS is basically diabetes of the ovary. It's insulin resistance in the ovary. And the ovary stops, it just has a hard time releasing enough estrogen, and it all gets converted into testosterone. And then the ovary gets confused because estrogen stimulates that ovary to release one follicle so that a woman can get pregnant. And it gets confused. It doesn't know what to do. So it builds up multiple follicles, and then we call it cysts, polycystic ovary. There's poly means many, cystic means these are fluid filled. So metabolic disorder is a number one driver of hormone disorders in young people.
So in that case, you would treat the metabolic first, not the hormones first.
Always. So one of my patients at this clinic came and said, "Oh, I can't get pregnant. I've done in vitro fertilization 2 or 3 times. I've been on Clomid and I can't get pregnant." And I said, "Oh, tell me, this was a telemedicine client. They weren't here." I said, "How old are you?" They told me their age. "How tall are you?" "I'm 5'6". "How much do you weigh?" 270. I said, "Okay, that's the problem. That's why you can't get pregnant, because this problem is driving this problem. And I can give you Clomid all day long. It isn't going to do anything until you fix this." So our entire focus for her pregnancy was fixing metabolic disorder. And guess what happened? She got pregnant. because this always drives this. So I think that's your question. In your case, you're not menopausal. If your hormones are a little bit wacky or you're trying to figure that out, this is the focus spot. We focus on this and this will get better. Not always, but most of the time. Excellent question. Any other questions today?
Just ask online.
Miss Gina, anyone else online have a question?
No, it's been very thorough. Thank you so much.
You're so welcome. Nice to see you. Okay. Well, I think we should wrap up because I gotta run home and build more PowerPoint slides.
Yeah.